All right, Dr. Rios, the audience is starting to flow in, and you can take it away whenever you prefer.
Okay, I'll go ahead and get started. So welcome. Tonight we have the National Hispanic Medical Association's All of Us Research Program, Fireside Chat Series, Session 5, Women and the All of Us Research Program. I'm Dr. Elena Rios, President and CEO of the National Hispanic Medical Association, and I want to welcome all of you. We have participants joining us by Zoom and also by Facebook Live. So we have two presentations that will be done, and then we will have a Q&A by our panel of 4 experts tonight. I just want to mention that our microphones for all participants will be muted. Then the recording will be available next week at our website, nhmamd.org. And if anyone has questions for our Q&A session, please put your questions in the chat box, and I will be asking questions then. We have a strong interest in research and introducing those participants, all of you, to be able to think about research and how to help your communities, your patients, your colleagues learn about the importance of the All of Us research program. So to start the session, I'm going to introduce Dr. Sarah Temkin, the Associate Director for Clinical Research out of the Office of Research on Women's Health at the National Institutes of Health. Dr. Temkin.
Thank you. I'm hearing a little bit of an echo, but thank you so much for having me. I'm very pleased to be here today to talk a little bit about clinical research and specific a few specific things to women's health, but also my real passion is clinical research and how we include a diverse group of patients into our clinical trials. If you can go to the next slide. Because I'm here today representing the Office for Research on Women's Health, I wanted to just start with a few definitions. We often consider sex and gender as one component. However, they really have different definitions. Sex is a biologic category that's determined by our chromosomes, and then also refers to the hormonal milieu that's created by those chromosomes. And every cell within our body has a sex that affects behavior, perception, but also how we develop diseases, how we respond to treatments. Gender is a social construct that integrates cultural and historical ideas about the way that we're supposed to behave based upon our biological sex that's assigned at birth. And this also has influence across our health, across our lifespans, in that gender determines some of the things that lead to health, including exposures to disease through employment or not. Also gender drives some of our relationships to our families and how our families are receive health care. If you could go to the next slide. Sorry, you could keep going. So why is inclusion important for clinical research? Clinical research is really, the purpose of clinical research is to determine whether an intervention is going to be useful to an entire population. So it's been very important to the National Institutes of Health to seek a distribution of participants by sex, gender, race, ethnicity, and age to meet a study's goals, which are to determine whether an intervention is useful in a population. In the 1980s, the NIH first realized and Congress established and formalized that women needed to be included in clinical trials. Also that we needed inclusion of a diverse group of racial and ethnic populations within our clinical trials. And more recently, this was extended through the 21st Century Cures Act, which really expanded inclusion to include age as a criteria, as well as pregnant and lactating women. And it requires the NIH applicable phase 3 trials or trials of interventions that are going to be led to the public, report results that include results specific to sex and gender, race and ethnicity. If you could go to the next slide. And so this is just to really drive home the importance of having a diverse group of patients in every clinical trial, because if the group of patients that are being studied doesn't match the group of patients to which our population intervention is being targeted to, we won't know if the intervention is actually useful for everybody. Some of the more common things that we see that influence this are something called the healthy volunteer effect, which is where people who tend to volunteer for trials are healthier. And we've seen this over and over again, especially in women's health trials, that oftentimes nurses are enrolled more than other professions, and they tend to be healthier than the general population. But it's beyond gender. It also speaks to the importance of race, ethnicity, age, and ability, that we're matching these things in our experimental population to who we want to become healthier. The next slide. The inclusion of women into clinical research has really had many different challenges and barriers over time, although these challenges are dissipating to some degree. And we do have about 50% of clinical trials participants in NIH-funded research who are women today. However, this varies widely across trials. There's historically been less research on diseases that affect women, and inclusion criteria have favored the inclusion of men over women into many clinical trials. We have historically assumed male animals and cells as the default, and so all of our preclinical research may not be the exact right lead-in to trials that include women. Also, women have unique challenges related to time, and there are time commitments to participating in clinical trials. Women and racial and ethnic groups may have different comorbidities and trust in the healthcare system, which may also limit participation. The next slide. Not everybody knows that you don't have to be sick to participate in a clinical trial. The All of Us research program has the goal of enrolling 1 million or more diverse participants, which are disease agnostic and come from all health stages, so healthy, not healthy. And the focus is really on disparity and diversity. So the goal is to include at least half of the population that comes from a traditionally underrepresented in medicine population. The focus is really on engagement, so that participants are included from the beginning and across the entirety of the trial. And all the participants will get their data back. So patients who are enrolled will provide health survey, but baseline questionnaires, measurements, biospecimens, and information obtained from devices. The next slide. And this is to date what enrollment has looked like. The goal of enrolling more than half of the participants who are from traditionally underrepresented in medicine populations has been to date upheld. About half of the population is white, a little less than half of the population is white, and all ages have been included today. There's also been a variety of people from gender identities and sexual orientation who have been included. The next slide. And so I just wanted to just say that clinical trials is part of the Office of Research on Women's Health mission, which is to enhance and expand women's health research, include women and minority groups in clinical research, and promote career advancement for women in biomedical sciences and careers. And this really is aligned with the NIH vision on women's health research, which is to incorporate sex and gender in an integrated fashion into biomedical research, make sure that every woman receives evidence-based care and that women in science reach their full potential. The next slide. This is traditionally what women's health has looked like. It has been focused on reproductive health issues and how women are different from men, but we have really learned from decades of this that women are not small men. And we'd like to endorse a philosophy where women are considered from head to toe, and we focus on the general health of women and how sex and gender impact all diseases and treatment. Next slide. I think there might be an animation here. Yeah, you can go on to the next slide. And this also has the animations in it. This is the multidimensional framework of how all factors influence the health of women across their lifespan, from preconception to childhood, adolescence, and adulthood. If you could click forward. There's a biologic perspective to be considered, which includes sex, our genetics, our molecular and cellular physiology, and how that intersects with our lives across our life course. And then the next click is the external factors that influence women's health. And this is the gender, the environment that we live in, and the policies by which our environment is regulated. And the next slide. These are some of the Office of Research on Women's Health signature programs. We support the Birch program, which is a interdisciplinary research career program for junior faculty who are interested in women's health to help support and develop their careers. We support specialized centers of research excellence, and these are disease agnostic research centers focused on sex differences between males and females. We have several administrative supplements that are focused on research on sex and gender, as well as understudied, underrepresented, and underreported programs, and then several R01 programs as well. The next slide. Also, if people are interested in how to create diverse patient populations for clinical trials, we have an inclusion outreach toolkit that goes over principles of clinical research and how to include a diverse population into clinical research. And the last slide is our e-learning programs that the Bench to Bedside program integrating sex and gender is really a great course for anybody that's interested in science. And the sex is a biologic variable primer, as well as introduction to the scientific basis of sex and gender differences. And this is really the last slide. If you wanted to connect with the office, here is the information, and we have a monthly newsletter that you can sign up for. And again, it's a real pleasure to have been here today.
Thank you, Dr. Temkin. Now we're going to hear about women's health research and nursing practice from Dr. Michele Crespo-Fierro. She's the clinical assistant professor and the director of lead honors program at the NYU Meyers College of Nursing. I believe she's also the New York chapter president of the National Association of Hispanic Nurses. So Dr. Crespo-Fierro, very nice to have you.
Thank you so much. I wanted to also make note that I am a member of the Association of Nurses in AIDS Care and serve on the board of the Greater New York City chapter of the Association of Nurses in AIDS Care. And I have a connection, as we had discussed before, with and the National Hispanic Medical Association through the Hispanic Health Foundation scholarships. I was honored to receive a scholarship while I was working on my doctorate back in 2011. So I am very grateful, and it's a very special place in my heart with NHMA.
Good, great, thank you.
Friends and colleagues and students that have also received scholarships. So I'm very, very, very pleased to have this opportunity to be with all of you. So if we can go ahead and advance to my next slide. So I wanted to provide, I guess, a little more of, provide a little more discussion about some of the many of the items that Dr. Temkin had mentioned in her presentation. And really, we need to kind of go back to this whole idea, this concept that the male body was the ideal, and really the only differences that existed were related to the sex organs and reproductive functions. And even that, you know, it really was thought that any type of research that was done on men was enough information to be applicable to women, to be applicable to children, to other people. And it really was this white male ideal that was sought out in most research. And we could go on and on and on about the instances where, you know, we focus on. If we talk about Freud, we could get into a lot of that, you know, just the whole idea that a woman was just wishing to be a man and not being able to manage. And that was, you know, some of the cause of some psychological and psychiatric issues. And even with that, the experiences of the menstrual cycle and other reproductive related activities, physical and emotional, were seen as disordered. You know, our terms of hysteria come from the, you know, the term for the uterus. So these ideas that women were less than. And there's also a history, and I think we need to make sure that we talk about it here, you know, with because we are focusing on Hispanic health for women, that Black and brown women's bodies have been manipulated in the past to discover medical care practices that were really intended for white women's bodies. And that's an important discussion for us to have. Can we advance to the next slide? So just to give those examples, I'm sure Dr. Marion Sims is well known, particularly for his work forcing enslaved women to endure those gynecological procedures without any type of anesthesia, repeatedly in awkward physical positions to develop treatments for vesicovaginal fistulas. But the speculum, he discovered the speculum as well. So, but we, you know, where he was considered the father of gynecology and gynecological procedures, we see now the irreparable harm that he has caused. And he is one of many instances where you know, people of color were mistreated regarding studies, whether they're official studies or, as in his case, some unofficial studies that he was taking on. But the other thing is, and this is something that maybe a lot of people do not know, when the oral contraceptives were being studied, the dosages were being tested, et cetera, they moved those studies to Puerto Rico. And for a very specific reason, to be able to have access to a population that was interested in some type of birth control. And the reason being, it was a Catholic country, and the types of birth control were looked down upon, particularly the use of condoms was looked down upon. So this was seen to be a way to be able to have, to control one's fertility without it being known to others. So this was an attractive proposition to the women in Puerto Rico. But the other thing, again, so knowing that it's a Catholic country, going in there and offering something that, well, depending on how you look at it, goes against their religious beliefs. But also, during that time, there were very specific restrictions regarding the use and the testing of birth control on the US mainland. So this whole idea that, oh, well, these restrictions did not exist in Puerto Rico. So, because it is not a state, we know that it's not a state, it's not it belongs to the US, but it's not part of the US. So this was a loophole that was manipulated. And during those early tests, there were higher dosages that were given, and really women were not given the information that they needed regarding reporting potential side effects. And we do know specifically of 3 deaths in women who were part of these studies, but there was no investigation, as for an example, happened when we had those instances of blood clots in relation to post receiving the Johnson & Johnson COVID vaccine. So those were not looked into. So we really don't know whether or not what were the cause of those deaths. Were they truly connected to the birth control pills, whether it's the dose or the, whatever that was. That said, the trials continued in Puerto Rico, even when it got to the point where we were studying it in the US, and American women were complaining about the side effects, were complaining about medical events, and the lawsuits began in so this trial was not ended in Puerto Rico until 1964. So here's again another example, and I bring these up because it creates this whole idea of being overlooked, and that's been the past, right? So it helps us to understand why there may be reluctance when we're seeking people to participate, to diversify our participants in clinical trials. Well, people will go back to what the history has been, and they're not sure, can they trust what's going to happen? If we could advance to the next slide. So what are the benefits to nurses, right? So there are quite a few benefits, and one of which is who we are and what our role is in the healthcare system and providing care. So our role is to protect, promote, and optimize health and abilities, prevent illness and injury, facilitate healing, alleviate suffering through diagnosis and treatment of human response. So we focus on the human responses to actual or potential health conditions. And we advocate for individuals, groups, communities, and populations. We also emphasize the use of research within our practice. So we have evidence-based practice, and we rely on that information that comes from clinical trials to help us plan our care, also to help us educate our patients. We often take on the role of patient educators, and we support people in their enactment of the self-care activities that are required in response to a diagnosis. So having that information is very helpful to us. But nurses are also researchers in their own right. So they also create studies, design studies. We're not just part of the research team, but sometimes we are the leaders of our own teams as well. So this is also important to us. And we also have a history of being very close to our patients, which has helped us to gain their trust, and for 19 years running, being the most trusted profession throughout in the US. Next slide, please. So here are some really, easy examples, and we can get into a lot more. But again, the reason why we need to have this focus and emphasis on women's health and presentation and for women particularly. And as we all know, heart disease, the symptoms of a heart attack are very different than those that we see commonly in men. And many women, unfortunately, heart disease is the #1 killer for women. And we've lost many women because they were waiting and expecting and thinking, oh, I need to have this list of symptoms because that's the information that's been put out there. That's what's out, that's what's commonly known. And I don't have the crushing pain in my chest. So I must not be having a heart attack. So I'm not going to go to the ED. But we know that oftentimes the presentation is very different for women. It could be stomach upset. It could be an overwhelming anxiety. And there are other symptoms that we often see. My particular history is for my mother, her symptoms of a heart attack were a cough. And for her, as an asthmatic, she often did cough with lots of, and she also had allergies. So that was missed. And a lot of damage was done to her heart because she wasn't having those typical symptoms. Another area, particular to HIV and AIDS, which is one of my areas of specialty, because overwhelmingly at the beginning of the epidemic in the early 80s, the majority of the people presenting with HIV were men. We were really identifying that presentation as we saw in men. But there were many women who were also impacted and diagnosed and at risk, but their presentation was different, right? So, and it really wasn't until 1993 that the CDC altered that definition to include conditions that were specific to women. And then from there, and this was incredibly important because it does get to some of the issues that Dr. Temkin was bringing up before. You needed an AIDS diagnosis in order to be able to access the assistance that people would need, to be able to get the insurance, to be covered by Medicaid, for example, to be able to access, at least here in New York, certain resources to help these women be able to stay at home and take care of their families. So this was a very important change that recognized that, that there are other ways in which HIV and AIDS presents. So that was a very important change. Can we go ahead to the next slide? And I do want to, and I'm not going to go over this in detail, but I did want to provide, so there is a National Institutes of Nursing Research, their own offices, and these are some recent highlights of nursing related research, many of which are focused specifically, this list particularly, on women's health. So here are just some examples of the way that nurses are engaging in research, particular for women's health. And then if we could advance, I think that may be my last slide. Yes, it was. Thank you so much.
Thank you, Dr. Crespo-Fierro, and thank you for all you do in New York. Also from New York, our next speaker, who will be part of our panel now, Dr. Nelly Correa, or Nereida Correa, is our NHMA Board of Directors Chairwoman. And we also have with us Dr. Ana Maria Lopez, who is the Chairwoman of our Philadelphia chapter of NHMA. And Anna is also Professor and Vice Chair for Medical Oncology, involved in a lot of research with the Sidney Kimmel Medical College, Jefferson University. So welcome to you both. Let me have you both introduce yourselves just for the audience to know who you are, and then we'll have a question and answer. And let me remind everybody to please submit your questions in the chat box at the bottom. Thank you. Nelly, do you want to go first?
Well, it's a real pleasure to be here with all of you, and I want to thank Dr. Crespo and Dr. Temkin for bringing up these very important issues in women's health. I am an OBGYN and a women's health specialist in the Bronx, and part of my work includes teaching medical students and doing clinical research with them, and also taking care of patients. So I have a practice in the Bronx that actually participates with all of us. And I am in the public hospital, North Central Bronx Hospital, doing deliveries and such stuff. But I really am impressed with the background, because I think that it's really important for us to look at what has happened in women's health over the years and the atrocities, and including what Dr. Crespo said in Puerto Rico. There also was a forced sterilization where women were not consented and were sterilized. And there was, all of the things that we talk about in New York with Dr. Sims, but also in New York, we had a lot of issues around, so much so that Dr. Helen Rodriguez-Trias, who was a hero of all of us, actually activated to make sure that in New York, women sign a consent 30 days before they actually have a tubal ligation. Because not only was it happening in Puerto Rico, it was happening in New York, and women were being told that it was reversible. So it's not really a surprise that women are having reluctance about joining clinical trials or doing some of the activities that we recommend with them when we're doing a research survey, and we ask them to answer many questions and do stuff like that. But we really need to convey to them how important it is for them to participate, because, if they have hypertension, they're being treated with drugs that were tested on men for the most part, and nobody really knows. And we know that there are certain drugs in pregnancy that women cannot take. But, when they're not pregnant, of course, they're candidates for some of those good drugs. So, like getting into good trouble, I think I always tell my patients that they really, if they want to benefit from some of the things, they do have to participate in some ways, and this really has come up big time with COVID, because in my practice, I can't tell you how many women, have had their whole families affected, and they've been taken with COVID. And yet, many of them are declining the vaccine because they're suspicious about how quickly it was developed, or so many. So we're doing some research on that too at NCB. We're running some focus groups with the community to see why the African-American, Hispanic populations are really saying no to the vaccine in many cases, and are needing so many incentives. I mean, they're giving free tickets to all kinds of things. But anyway, I'm going on too long. I'm going to pass it on to Dr. Lopez and then we can chat later on. This is a chat.
Thank you. Thanks, Nelly. It's a great pleasure to be with everyone. It's like being home. It's and great presentations. My name's Ana Maria Lopez. I'm a medical oncologist, and I do clinical trials. And although some of them are around treatment, I'm very committed to prevention. And I'm very committed to cancer risk reduction, helping people live well if they have a diagnosis, and understanding how to do that. And also in reaching everyone. You know, one of the things about clinical research is that it often is the leading edge, but not everybody has access to that leading edge. So how can we work, for example, with promotoras, with community health workers to get research trials to everyone? So that's part of my work. And NHMA, former member of the board of directors and longtime fan.
Mm-hmm. Okay, well, I'm going to go ahead and ask some questions. I'm going to ask specific people, and feel free to jump in, everyone. But let me ask Dr. Tempkin first, and then Ana Maria Lopez. Why is it so important for people in underrepresented communities to participate in medical research? And how can the All of Us research program help, get the message out to our underserved communities? Oh, you're muted, Dr. Temkin.
Sorry. I mean, I think I touched a little bit on this in my presentation about how important it is that we have representative inclusion, but also into clinical trials to make sure that our interventions are then applicable to the whole population, or the population to which we want the intervention to be applied. And someone a few minutes ago said something about drugs during pregnancy, right? So 70% of women take drugs while they're pregnant, prescription drugs or prescribed drugs while they're pregnant, but we've tested a minority of those on pregnant women. So we don't really know that they're safe. But in terms of participating in healthy volunteer studies, we just have so little data on what the actual differences are between communities and health in this country, because we've made so many assumptions over the years. And so people blame a lot of health disparities on comorbidities or biologic differences, when there are many environmental reasons and community reasons and health behaviors that are potentially modifiable that we don't even know about because we haven't been collecting that information.
Mm-hmm. Ana Maria?
Yeah, we're a diverse country, we're a diverse planet, and we're very similar as humans, but there are also some differences. And if everybody's not included, if there's not adequate representation, especially, for example, there may be some illnesses, for example, pregnancy. Only women are pregnant. The only way we can know the impact of medications on pregnancy is if we study this on women who are pregnant. Mm-hmm. I'm always reminded, I participated in the Women's Health Initiative, which was, a very, very large study that really focused on the health of women. And one of the cartoons that we had at the time is we had two male scientists talking and saying, I've studied Drosophila, I've studied frogs, let's study women. So we want to really be inclusive because we want our studies to make a difference.
Yeah, definitely. Well, let me turn to Michele and about nurses. Why are nurses a natural community partner for the All of Us research program? And again, how can the All of Us research program help both nurses and their patients get more involved with this wonderful program?
So, well, we actually have quite a few nursing associations that are connected to the All of Us program and part of the campaign. at the specialty level, as well as what we call the Affinity Nursing Association. So the National Association of Hispanic Nurses, the Black Nurses Association, the Filipino Nurses Association. Many of those are involved to assist with that outreach. And we're very happy to be doing that. But I think for nurses, and why it's such a nice fit is it's because of that closeness that we have oftentimes, the amount of time that we spend with our patients, whether they're in the hospital, they're in the home, or we're encountering them in the communities and schools and in places of work. And we have this great opportunity to see them, to see who they are, to hear what their concerns are, and really have that opportunity to answer their questions and sometimes get at what the real question is, right? So there's the first question, which is kind of that first layer, but there's really something underneath that they maybe don't have the words for, or are afraid of asking, afraid of offending someone. But we get to do that. And specific to, for us, it's that confianza that we get to build. And that trust is really important. And when we're working with them, when we have an opportunity to work with them long term, we get to walk with them, acompañarlos through the process, through whether it's their health journey, or if they are looking to become part of research studies, to walk them through that process and make sure that that informed consent is every time they are engaging, with the researchers and with the program and the study, that they understand all the way through, not just day one, but day 50, day 365, whatever, however that's set up. So it's a great match for us. Absolutely.
So Anna Maria, if you can pick up on what Michele mentioned about trust, I think it's so important to expand on this in your work in research and also in the Philadelphia region. What are some of the ways that you've used, to communicate to your patients or to others about the importance of trust, especially given the context of the COVID-19 pandemic, when everyone's staying home and not trusting anything or anyone, and especially for Latinos who have a real mistrust of because of prior history, as was mentioned earlier, about government research, and especially as we have vaccines that are right now that are being rolled out. And it's so important to gain the trust of people to participate in all of our programs and campaigns. What do you think are some tips for communications?
We are in a time where we don't trust anything.
Right.
And our institutions are being questioned left and right. So it's a time for us really to earn trustworthiness for our patients, our communities, our colleagues. And part of it is simply being there, having staying power. Part of it is, when you speak with someone and, Michele, when you speak to somebody in their own language, when you speak to somebody eye to eye as opposed to looking down, all of these, I think, make a difference to people. It's for us to kind of shed the white coat and really be human with each other and show, I would say in medicine, ours is an ethic of care. And I think in the same way for research, that's critical to healthcare.
And Nelly, let me ask you, could you expand upon this issue of communication and the importance of the Latino health professional, nurses, doctors, pharmacists, there are so many health professionals in our communities, but very few Latinos. So what is the role of the Latino health professionals? What's the unique role in fostering, again, trust and participation?
I think that it's an amazing role that we have, and there's so few of us because, as we know, the percentage of physicians is the same as it was, nurses is short, or researchers. But I think that what I find with my patients is that they find such joy when they find out that you can speak their language and you can actually communicate with them about things that, that we have in common in terms of diet, in terms of different experiences. So it's invaluable what we bring to the table. And it's really important for us to bring more of us to the table, to recruit students and to mentor students so that we can bring more people to do this. I think our patients value those interactions that they have with us, and they seek us out. And it's very difficult for them when they come to and that's true for any culture. If you come to a provider and they don't speak their language, and then they have to get on the phone, and interpret, it's just not the same. So the idea, the whole simpatico, they leave more joyful. The other thing is, I think that when there's a visit, it's not just a visit about the person. It's how is your family? How are you doing? Did anybody get COVID? Are you taking the vaccine? Are you doing everything that you should be doing, to prevent yourself? So all those things, like all of it comes to the table when we're having and especially in a research situation where there's already distrust. I think that it's very important to be able to explain to the patient in their own language and to be able to give them an opportunity to ask questions and to say, what is this going to do to me, and things like that, to give them that opening that they should ask questions.
Thank you all.
I just wanted to add to that a provider recommendation is the number one thing that's going to help patients feel comfortable enrolling on a clinical trial, and that really speaks to the trust that the patients have in their providers, and also how important it is to have a diverse workforce, because we know that women who have a cardiac condition do better when they have women providers, but also when they have a male provider who has a woman with a woman colleague, that man is going to do better than a male cardiologist that doesn't have women colleagues. So there's a real importance to diversity in the workforce.
Very good. So Dr. Temkin, because you're from the Office of Research on Women's Health and probably closer to the some of the thoughts behind the All of Us research program for women, there's a couple of questions in the chat box. What do you think about the All of Us study in looking at allostatic load and stress on women's health, especially Latinos and African American stress? And also, let me just ask this question, anyone else can answer, but I want to see if Dr. Temkin, if you had some thoughts about this, about the cultural background of women, not just how they identify or, but also their culture in terms of, I would say, the All of Us research programs, development, and also to include more participation.
Yeah, I think I may not answer this question exactly, but I know that stress is a biologic variable to help explain racism and how racism's and its impact on health, as well as the health of traditionally underrepresented in medicine communities. I think that is really becoming more of an interest. I think as we've seen these very large inequities in COVID, and it has really sparked a lot of interest in the extramural community as well as inside the NIH to really examine the impact of stress on health and how stress is differentially experienced amongst different communities, including women. And we definitely, and I think that's the number one reason that we're defining sex and gender separately, is so that we know that it's not just our cells and our cellular makeup that's different, but it's also the way that we perceive the environment and we're perceived by the environment that impacts our health.
Mhm. Anyone else want to add?
There's a lot that we need to learn here, really. And I'm very interested in this whole mind-body connection.
Mhm.
And that's influenced by the environment, and we influence it. So how does that all work? How can we modify? What are the ways that we can help people? And you know, it's not that we don't have to change the environment, because in many ways the environment is toxic to human beings, you know, the stress that people live under. But how can we cope with it better and try to change it at the same time? So it's a pretty interesting cycle to understand. And it's the understanding biology, psychosocial, how all of these pieces really do interconnect.
Mhm. Michelle, let me just ask.
Let me,
Oh,
can I
Nelly,
add?
go ahead.
Yeah, I just wanted to add something. I think we have to look at the area of research in implicit bias and
Mhm.
look at that interaction with the healthcare environment and how implicit bias actually can impact on, you know, whether people accept things, whether they actually take advantage of any participation in any activities and things like that. And we as health professionals and also our students need to be trained in some way to recognize what some of these things are and how we can recognize that there is implicit bias. So this is a big field of research, which we in our school at Einstein are encouraging, you know, our students and also our faculty to partake in.
And, you know, building out on that, you know, the whole idea that sometimes it's the implicit bias that prevents or discourages the provider from making the suggestions to, you know, to go for this treatment or to, consider participation in a study, because it's just an automatic, well, they're not interested. They don't trust anyway.
Mhm.
Instead of going beyond that and asking those questions, really taking the opportunity to understand what their gendered experiences are. As we know with women, the caretaking responsibilities, not just the stressors of that, so managing oneself, the stressor of that and maybe working, but then the caretaking of parents, of children, of other family members, those responsibilities of having to, you know, be at, you know, such and such a place at this time, because that's the time to pick up the child. You know, all of that is really important. I want to say just one more thing about it is incredibly important that we do connect with our patients and our clients, be able to represent, be that face, you know, speak the language, understand the culture. But I'm always concerned that it's going to be, oh, you work here, you check that box, these are your patients. You're responsible for all of them. And it's, you know, and it gets a little bit to what Sarah was saying, that taking the opportunity and the time to learn, right? So, you know, that male physician working with that female physician is picking up on those things and bringing that into his practice. So others can learn those phrases in Spanish, and your patients are going to love you for saying that, you know, and understanding, you know, ask about the family. That's going to go so far to building that trust. So, yeah, it's not just other people's responsibility. It's all of our responsibility to do that.
We have a few minutes left. I wanted to ask one more question, and let's just again have a round robin answer here. You're all bringing up something very important, that the education of our patients is important for especially for Latino patients, to have Latino doctors and nurses, okay? But there's not that many of us. And I think what we need to tell the audience is, how do we, from our respective organizations, your academic affiliated groups, NIH, the Hispanic Nurses Organization, the Hispanic Medical Association, how do we help with training the next generation? Sarah, let me start with you. I know you mentioned a lot of different programs at the Office of Research on Women's Health. I think they're all great programs, but if there was one program you could mention that's important for people to know about.
Oh, I think that e-learning programs, if people want to check out the Bench to Bedside Sex and Gender program, I think it's just terrific. It's about inclusion, it's about science, and there's something for everybody in that.
Okay. Michele?
I think we have to prepare our pipeline. So we, honestly, I think high school programming is a little late. I think we need to start with pre-K. We need to get them when they just want to be everything and anything all at the same time. Yeah. But really making sure that all of our kids get the sciences and the academics, the math, the English, the language that allows them to take the courses at the levels that they need. So when they're ready for undergrad, they can get the scores that they need to get into the programs. Okay. Just encourage them. Yes.
Yeah. No. Starting young. Okay. That's great. That's great. Nelly, what do you think?
I believe the same thing, and I'm a great advocate for starting very, very early, because I think once the hormones hit, they don't really want to go to school. So you have to start early, and you do have to. The other thing that I find, though, and getting back to the thing about, well, your patients resonate to you because you're from their culture, I think that we have to include our colleagues in this, and that eventually, you don't have to be of a culture to respect and to understand what the practices of that culture are. And I always tell my students, you can work together. You don't have to speak Spanish. You just have to be able to communicate nonverbal or some way that you care. And the care part of it is, I think, what's really, really important. But again, you said, Elena, like you said, all of us, that next generation really needs to be taken in. They need to be hugged by us and taught, carefully taught that, what we have learned, that it doesn't get lost. Because what happens is, we're preaching to the choir often. But what about, the other 90% of people that believe this, and that? And it's not just Hispanic culture, like in the Bronx. We have Bangladeshi, we have Albanians, we have African Americans. So all of those cultures are really important to include what their beliefs are and what their practices are, so that we can be good providers for them.
And Anna Maria?
So yes, start them young. And there are actually programs that, third grade. Some literature would say that we need to capture kids before fifth grade. By fifth grade is really when it's like our sense of
preconception. Did you hear about preconception?
That's right. That's right. But that our sense of self, and it's that sense of I can. So I think being able to encourage our students, our children with I can. One of the great grant opportunities that I think is out there that is, I think, very, very rarely used is diversity supplements. So many grants are eligible for diversity supplements, and these can be for high school students. So one of the things I try to work on is kind of to be a matchmaker. You have a large grant award. Are there trainees, are there learners that may be able to work with you? It helps the learner, it helps the researcher, and it really adds to that pipeline. One more thing I guess I wanted to say is, there aren't that many of us. But because of the power that we have seen in the last year of Zoom technology or any other video conferencing type technology,
Yeah.
we really can be at more than one place at once. We can really be out there. And there is something about a young person seeing, you know, somebody like Dr. Correa, somebody like Dr. Crespo-Fierro, and can say, maybe I could do that too.
Yeah.
So I
Well,
think that something helpful there.
Let me add to this roundtable right now and just say that the National Hispanic Medical Association hasn't gone to preconception, hasn't gone to pre-K yet. And we're not even at fifth grade level, but we have had recruitment of not only Latino, but the local students around our national conference every year since 2007 to meet with our role models who come to our conference, and especially the students that are in the different health careers like nurses and dentists and doctors. And we also bring recruiters from these types of schools, right, to talk to students who might have questions, who are in high school or college and who may not be thinking of how to take the MCAT test or, you know, the NCLEX test, but they're thinking, well, what is it that I have to do to even think about this kind of a career? And we do have a program called the College Healthcare Scholars Program. And that is for college students. And again, it might be late, but I think what we've been able to show in the 2,500 students or so that we've picked up in the last 3 years, there's a lot of students, and again, they're not all Hispanic students, and they don't all want to be doctors. We ask them to think out of the box, to get involved in research, to get involved in nursing or medicine or dentistry or public health, but they all seem to be individually high achievers without role models, and they don't know what to do. So I think that, and I'm just going to end here with, I think that the All of Us program is a research program that needs role models to find more and more of the next generation to get involved in this program. And we need to have personal contacts, and in whatever activities the participants in this program are involved with, I think it's important that you let others know in your academic center or in your research area that how important the All of Us research program is, because if we don't do it, you know, no one else will. And I want to thank everybody for being on the program tonight and for all the participants. Again, let me just say that the National Hispanic Medical Association is very proud to partner with the All of Us research program. And we do have information here about our website, nhmamd.org. We also have an announcement about our national conference for next year. I want to give a plug since we have our dates now set. March 24th through the 27th, we will be at the Hyatt Regency, Crystal City, Virginia. And we are looking for research posters from students, from faculty. We are looking for speakers. And of course, we will have All of Us research program there. And Dr. Tempkin, we'd love to have the Office of Research on Women's Health. And Michele, we'd love to have the National Association of Hispanic Nurses. And Nelly and Anna Maria, of course, we'd love to have you as speakers at our national conference. And so we invite everybody to join us. And I think it's so important, again, to partner with NIH and the All of Us research program. So thank you very much, and good night, and we'll see you next time. Bye.
Thank you.
Mhm.